It is my pleasure to introduce today's speaker, Dr. Kent Lamb, Associate Professor and Chief of the Division of Rhinology and Endoscopic Sinus Skull-Based Surgery in the Department of Otolaryngology at Macon and John Brock, Virginia Health Sciences, affiliated with EVMS Eastern Virginia Medical School and Old Dominion University. Dr. Lamb's career is a testament to excellence in both clinical practice and academic leadership. He attended Harvard College and received his medical degree from Georgetown University School of Medicine. He was elected to the prestigious Alpha Omega Alpha Honor Medical Society. He completed his residency in otolaryngology at Northwestern University and further on his expertise with a fellowship in rhinology and anterior skull-based surgery at the University of Texas Health Science Center in Houston. Dr. Lamb's clinical interests encompass a wide array of complex conditions, including chronic rhinosinusitis, sinonasal cancers, cerebrospinal fluid leaks, and smell and taste disorders. His leadership extends beyond patient care to his contributions as a member of the American Rhinologic Society and the American Academy of Otolaryngology, Head and Neck Surgery, where he has served in pivotal roles, including chairing the Continuing Medical Education Committee and contributing to the clinical guidelines. A prolific researcher, Dr. Lamb has led and participated in numerous studies. He has received several accolades, including being named as a top doctor by multiple organizations and receiving awards for his contributions to medical education and research. Today, Dr. Lamb will be sharing his expertise on contemporary medical and surgical management of chronic rhinosinusitis, offering insights from his extensive clinical and academic experience. Please join me in welcoming Dr. Kent Lamb. Thank you for taking time out for us. Over to you, Dr. Lamb.
Okay, thank you, Dr. Misrat, for the generous introduction. It would have been nice to have been able to join everybody in person. I know you guys are in a very nice facility. We have our monthly grand rounds with the otolaryngology department in that room, but unfortunately, I'm stuck at home with COVID. So. Very happy to be able to join everyone virtually, however, to share my my experiences managing patients with chronic rhinosinusitis. So here are my disclosures. So the objectives for today are to highlight what characterizes chronic rhinosinusitis by both patient-reported and objective criteria. Chronic rhinosinusitis is a disease with significant variations, and we will discuss the evolving manner we are able to differentiate the different subtypes today. We'll also review the medical therapeutic options that are available for CRS patients, and of course, lastly, when medications are insufficient to provide patients with the symptom relief that they're looking for, we can further explore surgery as a treatment option. In all, medicine is increasingly becoming more centered on shared decision-making, and I emphasize to patients that the therapeutic options that we can offer to them is based on how big of an impact chronic rhinosinusitis is having on their quality of life. For me as a rhinologist, it's been extremely gratifying. I've had a very gratifying experience to be able to manage patients with chronic rhinosinusitis, because chronic rhinosinusitis, as we'll discuss, is a quality of life condition. Patients, though, suffer immensely from the symptoms associated with chronic rhinosinusitis, and with both medical therapeutics as well as surgery, we're able to improve their quality of life. To start, we'll discuss the diagnosis of chronic rhinosinusitis. The paranasal sinuses are compartments within the facial skeleton located inferior to the inferior vault, intracranial vault, superior to the oral cavity, and between the orbits. These images of the cadaveric specimens, as well as the CT scans, show that there are two sets of sinuses, one on the right side and the left side. The sinuses have many functions, including reducing the weight of the skull, humidifying the air that we breathe in through our nose, and also contributing to the resonance of our voice. There are four sets of sinuses: the maxillary sinuses, which are located in the cheeks, the ethmoid sinuses, which are located between the eyes, the sphenoid sinuses, which are located behind the eyes, in the back of the nasal cavities, and then also the frontal sinuses, which are located in the forehead. Each of these sinuses are lined with respiratory mucosa consisting of pseudostratified ciliated columnar epithelium that is important in the production of nasal mucus and also in the removal of air particles that we breathe in into the nose and into the sinuses. As rhinologists, we have the ability to perform nasal endoscopy to visualize the anatomical structures of the nasal cavity. Here, I'll show a video of a nasal endoscopy that shows a patient's left and right side. Here is the left side. We're able to highlight moving through the nasal vestibule. We're able to see the nasal septum as well as the inferior turbinate. Here is the right side, and straight ahead is the middle turbinate. And within lateral to the middle turbinate is the middle meatus, which is where the sinuses are able to drain into the nasal cavities. We're able to assess the health of the nasal mucosa, which is supposed to be pink and thin, as we see in this particular patient. While we're not able to look directly into the maxillary, frontal, and the sphenoid sinuses, nasal endoscopy of the middle meatus allows us to really identify if there's any disease within the areas connecting the sinuses into the nasal cavities. This disease may reflect infection if there's any evidence of pus, inflammation with polyps or tissue swelling, or neoplasm or foreign bodies if there are any masses in this area. Besides assessing the nasal and paranasal sinus structures, we're able to use nasal endoscopy to help perform sinonasal procedures, including in-office nasal debridements and biopsies, and also OR-based endoscopic sinus surgery. So what is chronic rhinosinusitis? As seen on the figure on the right, chronic rhinosinusitis is a disease defined by inflammation involving the mucosa that lines the nose and paranasal sinuses. The inflammation results in swelling of the tissue and subsequent blockage of the nasal drainage pathways of the sinuses, which becomes central to the manifestation of the associated symptoms. Chronic rhinosinusitis is a chronic condition that persists for 12 weeks or more, and in most cases, once chronic rhinosinusitis is diagnosed, we tell patients that they are at risk for development of symptoms with acute exacerbations for the rest of their lifetime. This distinguishes chronic rhinosinusitis from acute rhinosinusitis, which refers to a more acute viral or bacteria process that lasts for less than 4 weeks and is associated with a sudden onset of symptoms. Prevalent symptoms include nasal congestion, facial pressure, discolored nasal drainage, smell alterations, and these are the cardinal symptoms of chronic rhinosinusitis. Fever and cough are also common symptoms, but these symptoms are not the critical ones we assess for and ascertain in chronic rhinosinusitis due to the overlap of fever and cough in other medical conditions. So chronic rhinosinusitis imparts a high personal and societal burden in the United States and also globally. In the United States, the prevalence of the disease is as high as 17 to 17%, and it incurs a lifetime of medical and surgical resource consumption, which adds to the economic burden of healthcare expenditures. These costs include direct medical costs in order to manage the disease, and also indirect costs attributed to the consequences of illness, such as lost productivity at work and school, and also time spent traveling to receive care for chronic rhinosinusitis. For individual patients, chronic rhinosinusitis results in a significantly decreased health state utility value for when compared to patients who do not have chronic rhinosinusitis. The health state utility value indicates a significant impact on chronic rhinosinusitis patients' overall health due to symptoms like facial pain, nasal obstruction, and reduced sense of smell. Fatigue, bodily pain, sleep dysfunction, and depression are also common in chronic rhinosinusitis patients, making the impact of chronic rhinosinusitis on par with that of other chronic illnesses, including asthma, coronary artery disease, and also COPD. However, the good news is that health utility state values for chronic rhinosinusitis can improve following the initiation of treatment, as well as surgical interventions for chronic rhinosinusitis. The concept of chronic rhinosinusitis is relatively new because a true diagnostic criteria for chronic rhinosinusitis was only formulated in 1997 by the American Academy of Otolaryngology Head and Neck Surgery. Today, these diagnostic criteria are important in determining whether patients with a variety of nasal and facial symptoms truly have chronic rhinosinusitis and warrant the treatments that are available. To diagnose chronic rhinosinusitis, a patient must experience at least 2 of the following symptoms for a duration of 12 weeks or longer. These symptoms are the cardinal symptoms which were previously mentioned: facial nasal congestion or obstruction, mucopurulent drainage anteriorly or posteriorly, decreased or absent sense of smell, as well as facial pain or pressure. Furthermore, there also must be objective findings of mucosal inflammation within the paranasal sinuses on nasal endoscopy or CT scans. The image on the left demonstrates a polyp with overlying mucoid drainage within a patient's left middle meatus, while the CT scan on the right shows complete opacification of the paranasal sinuses. This combination of both subjective symptoms and objective evidence is essential in establishing the diagnosis. As previously stated, chronic rhinosinusitis is an inflammatory disorder that affects the sinonasal mucosa. A combination of intrinsic host immune variables and exogenous factors in the environment has been linked to the development of this inflammation, which is central to the manifestation of clinical symptoms. Despite the underlying role of inflammation, chronic rhinosinusitis is also well known as a heterogeneous syndrome of disease variants. These variants have traditionally been characterized as phenotypes according to different clinically observable features, including the presence or absence of nasal polyps. Responsive and also other factors used to phenotype chronic rhinosinusitis also include responsiveness to therapy and also other associated comorbidities like asthma and allergy. The distinction between chronic rhinosinusitis without nasal polyps and chronic rhinosinusitis with nasal polyps remains the most common method of identifying different disease phenotypes. And these the pictures seen on this slide depict a patient with chronic rhinosinusitis with nasal polyps on the left, and then the patient the image on the right shows chronic rhinosinusitis without nasal polyps, and the process is more of a infectious process. If the patient had symptoms that persisted for 12 weeks or longer. Even then, there are many significant variabilities within the different phenotypes. For example, comorbid asthma and nasal polyposis are generally more difficult to control than nasal polyposis without asthma, with higher rates of recurrence following surgery. So again, there are a lot of different variables used to characterize the clinical manifestations of chronic rhinosinusitis. At the base of chronic rhinosinusitis, immunology plays a central role in the onset and propagation of the disease. Advances in laboratory testing has heralded new understandings that the clinical heterogeneity of chronic rhinosinusitis is actually rooted in different immunologic pathophysiologic pathways which lead to this inflammation. The purpose of this very busy schematic is to show the complex inflammatory processes within various arms of the innate and acquired immune systems. What starts at the epithelial surface of the upper airway, whether that be viruses, bacteria, allergens, or other environmental insult, may ultimately result in inflammation as an end product. Many molecular cytokines and immune cells can give rise to this inflammation. As we are better understanding differences in the pathomechanisms of chronic rhinosinusitis, we are shifting the classification from chronic rhinosinusitis variants from observable clinical characteristics to the underlying pathways that result in the clinical characteristics. This signifies the shift from the use of phenotypes to the use of endotypes. Endotyping has become an important concept in all medical specialties in that it reflects a more precise understanding of the underlying disease mechanisms and applying targeted treatment strategies. I'll be using traveling as a metaphor to highlight the distinction between phenotypes and endotypes. While we're all at EVMS in Norfolk, we may very well have spent time in other parts of the country or the world. This flight map shows how we may come from different locations, but our journey all converged in Norfolk. While a phenotype represents a destination of our itinerary, which is here in Norfolk, the individual paths that each of us has taken to get to this destination reflects the different endotypes. What forms the crux of chronic sinusitis research today is identifying well-defined and easily accessible inflammatory signatures to characterize the chronic rhinosinusitis endotypes. Even today, current recommendations to phenotype chronic rhinosinusitis continue to be based on the presence or absence of nasal polyps and the association with comorbid diseases. But within these subgroups, additional layers of differentiation are based on certain biomarkers. One proposed method for endotyping chronic rhinosinusitis with nasal polyposis has been differentiating nasal polyps according to the presence or absence of type 2 inflammatory patterns, tissue eosinophil levels, IgE levels, and cystinoleukotrypsin levels. In fact, endotyping of chronic rhinosinusitis currently uses a classificatory system that consists of type 1, type 2, and type 3 inflammation, each of which are associated with characteristic cytokines, immune effector cells, and immune targets. The type 1 endotype is characterized by the preferential expression of interferon gamma produced cytotoxic T cells and natural killer cells, all of which are generally immune responses to intracellular viruses. The type 2 endotype is associated with the selective production of cytokines IL-4, IL-5, and IL-13, and basophils, eosinophils, and mast cells, which are involved with the cellular defenses to parasites. The type 3 endotype is associated with IL-17 and neutrophils, which are classically produced with bacterial or fungal infections. The importance of identifying endotypes in chronic rhinosinusitis is seen in implications related to treatment. As we are better able to identify different endotypes, specific treatments may be better tailored to the underlying mechanisms behind the patient's sinonasal inflammation. This may be seen in the development and use of biologic therapies, which has revolutionized the way we can manage chronic inflammatory conditions if we can identify specific targets that are specific to the individual patient's inflammatory pathways. The type 1, type 2, and type 3 methods of endotyping chronic rhinosinusitis, however, is not absolute. The allergy and otolaryngology group at Northwestern actually evaluated the association of inflammatory endotypes with their chronic rhinosinusitis with nasal polyps, as well as chronic rhinosinusitis without nasal polyp patients. As you can see in this graph, while nasal polyp patients were more aligned with a type 2 inflammatory endotype, about a third were non-type 2. Even some patients displayed a mixed inflammatory profile with the presence of multiple types of inflammatory cytokines. This suggests that multiple molecular and cellular immunologic pathways may work independently or in combination with each other in order to result in the ultimate formation of chronic rhinosinusitis and sinonasal inflammation as a whole. This highlights the continued need to correlate how certain inflammatory pathways may be associated with specific clinical features, such as the loss of smell, recalcitrance of disease, and the development of mucopurulence. So given the importance of endotypes, what are practical ways to gain endotypical data in our chronic rhinosinusitis patients? At the most basic level, the appearance of chronic rhinosinusitis on nasal examination may give more information about the underlying type of inflammation. For patients who have nasal polyps that appear glistening and watery and also have stringy mucus, these patients may tend to have more of a type 2 inflammatory component. Use of routine laboratory workup with peripheral blood counts may be also helpful. I routinely obtain a complete blood count to measure the absolute eosinophil level and as well as a total IgE level as part of a patient's initial workup when they are diagnosed with chronic rhinosinusitis. Furthermore, the association with comorbid diseases may play a big part in endotyping chronic rhinosinusitis. Here, this particular study that we performed here at EVMS looked at the association of chronic rhinosinusitis with concurrent allergic rhinitis and asthma and the predominance of eosinophilic levels, which may serve as a surrogate for type 2 inflammation. Patients with chronic rhinosinusitis and allergic rhinitis and asthma had a higher percentage of eosinophils in their tissue specimens than chronic rhinosinusitis patients with only one or none of these comorbidities. So at EVMS, we have worked to build a multidisciplinary collaboration with other specialties, including pulmonary, including allergy and immunology in the community, because the reality is that many of the challenging chronic rhinosinusitis patients we have in our patient will also have asthma and other chronic inflammatory conditions. An interdisciplinary approach to the management of these patients will be needed as we move forward with some of the new therapies that we have available for these patients. So once we're able to establish a diagnosis of chronic rhinosinusitis for patients who have the applicable sinonasal symptoms, the next step is really to try to recommend treatment strategies for these individuals. As a whole, chronic inflammatory conditions such as asthma, inflammatory bowel disease, and even osteoarthritis are generally treated with strategies that reduce the level of inflammation within the affected organ system. And this concept of using anti-inflammatory therapeutics certainly applies to chronic rhinosinusitis. Medications that reduce the level of sinonasal inflammation serve as the foundation of therapy to improve patient symptoms. And as a chronic disease, management of chronic rhinosinusitis may require the consistent use of medications. Oftentimes, patients will come and ask me if, after their symptoms resolve, can they stop use of the medications that I've prescribed? I tell patients that chronic rhinosinusitis is very similar to hypertension, to congestive heart failure, to asthma. As a chronic condition, there will be exacerbations that may require the continued use of these medications that we've prescribed for them. Furthermore, the typical medications that we use for chronic rhinosinusitis rely on topical therapies as opposed to systemic therapies. This is most notable with the use of steroids, which is preferred to be used through the topical administration due to the long-standing side effects associated with chronic oral administration. Over the years, the development of new medical therapies in our field really have widened the ability that we have to enhance the delivery of topical therapies into the sinonasal cavities and thereby to improve disease management. Given that patients are also stakeholders in their care, it is also important for them to understand why these medications are being recommended. And so oftentimes in talking to other healthcare providers about the different medical therapeutics we have to offer to patients with chronic rhinosinusitis, I often try to highlight the rationale that I provide to patients in explaining why these medications are helpful for them. One additional point that I will make here is that surgery is also offered to patients only after they failed an initial trial with medical therapy. But there are certain subtypes of chronic rhinosinusitis that are primarily treated initially with surgery. These include patients with chronic rhinosinusitis resulting from a fungal ball, and also patients who have advanced nasal polyps, as well as allergic fungal rhinosinusitis, where their sinuses are just completely impacted with the disease. In these cases, the mere use of medications will not likely evacuate the disease within the sinuses, and surgery is noted to help extract the thick debris as well as the disease that is causing the symptoms associated with chronic rhinosinusitis. So the concept of medical management of chronic rhinosinusitis has long been detailed by professional organizations across the globe. These organizations have included the American Rhinologic Society, as well as the American Academy of Otolaryngology Head and Neck Surgery. These types of treatment algorithms draws from the best available evidence. The schematic here is a summary of the recommendations taken from the International Consensus Statement of Allergy and Rhinology for Rhinosinusitis, which was most recently updated by leaders in the American Rhinologic Society in 2021. We can see that following the establishment of a CRS diagnosis, which is based on clinical history, physical examination, and CT imaging, the recommended treatment consists of various medical therapies, including nasal saline irrigations and intranasal steroid sprays. Both nasal saline irrigations and intranasal steroid sprays are regarded as first-line therapies for patients with chronic rhinosinusitis with and without nasal polyps. The treatment recommendations further suggest using either a short course of oral steroids and also potentially a macrolide antibiotic, but these are not prescribed for all patients because of the associated side effects with the use of these systemic medications. Furthermore, in regards to antibiotics, to get on a soapbox, as we are recognizing that chronic rhinosinusitis is more of an inflammatory condition as opposed to necessarily a infectious condition, we are starting to move away from the requirement of treating patients with chronic rhinosinusitis with a course of oral antibiotics, because if it's not going to help, there isn't a purpose in terms of incurring the potential side effects that come with the overuse of antibiotics. So in this schematic, the options also highlights some of the more advanced topical steroid therapy options that we have available for patients. This includes the use of topical steroids administered through nasal saline irrigations, as well as through a exhalation delivery system. Both the use of topical steroids through nasal saline irrigations is an off-label usage of steroids placed into nasal saline rinses, and then the use of intranasal steroids through an exhalation delivery system does require a prescription for these patients. So of note, the options with the red stars in the schematic are new additions to the algorithm, which was updated in 2021. These were not present in the algorithm that was initially published in 2016. So the purpose of highlighting these new additions is to show that the treatment options for patients with chronic rhinosinusitis is evolving, especially with topical steroids. There's a lot of research that is being funneled into bioresorbable implants, as well as different strategies to improve the deposition of topical steroids into the paranasal sinuses, and then also biologics, of course. For everybody in healthcare, we all know the power and the impact of biologics in managing patients who have chronic inflammatory conditions, who are refractory to the most basic of medications, including oral steroids. So there is, however, limited high-level evidence to offer what exactly constitutes as appropriate medical therapy. This chart here highlights a few proposed recommendations by different specialty organizations across the globe for medical therapy that should be offered to patients prior to sinus surgery. As you can see, there is a lot of variability in the duration, as well as the types of topical and systemic medications that has been recommended. Nasal saline irrigations and intranasal corticosteroids, as previously highlighted, are generally supported due to their effectiveness as well as their low side effect profiles, while oral steroids are recommended on a short-term basis if there aren't any contraindications in the patients. Nonetheless, this is a chart that was taken from the ICAR iteration, the International Consensus Statement of Allergy and Rhinology iteration from 2016. And as I've mentioned before, the use of oral antibiotics is no longer truly recommended as a prerequisite for patients with chronic rhinosinusitis before considering surgery for these patients. I was actually recently involved with the development of a guideline for chronic rhinosinusitis by the American Academy of Otolaryngology. And one of the statements that we included in this guideline, which will be published in the coming months, was to explicitly state that antibiotics should not be prescribed for chronic rhinosinusitis patients unless there is evidence of an active infection. The purpose of such a clarification is to avoid the overuse of antibiotics if there aren't any benefits to the use of this medication, but also a high risk of potential side effects. As mentioned in the previous slides, there is a list of recommended medical options for management of chronic rhinosinusitis. Here we'll look at some of the individual categories of medical therapeutics. Nasal saline is an important treatment for patients of all types of chronic rhinosinusitis. Studies have shown that nasal saline provides nasal moisturization and improves nasal symptoms by thinning and removing mucus, cleaning proteins that cause inflammation, and also flushing out nasal allergens. There are several application options for patients, including sprays, irrigations, and even a mechanical irrigation with powered suction. The large volume of nasal saline irrigations provides higher penetration into the posterior parts of the nasal cavities and thus improves the symptoms as well as the quality of life scores of these patients. There's the option of using both isotonic and hypertonic saline, and I tell patients that both of these saline tonicities are good. They can use whichever is preferable to them. And the merits of nasal saline are also complemented by its low risk of use. So what do I tell patients, when I encourage them to use nasal saline? I tell patients that this nasal saline is really just salt water used to perform nasal hygiene. Many patients at this time now choose to prefer not to use medications if possible. And so saline as salt water for the nose is a good way for patients to improve their sinonasal health, to improve their symptoms without actually using a medication. And then also I tell patients that it's simple for patients to perform nasal saline irrigations on a daily basis if they incorporate it into their grooming routine. If they're bathing on a daily basis, they can bring one of the nasal saline squeeze bottles into the bathtub or into the shower, and they can perform a rinse as part of their hygiene process. Next, the classic anti-inflammatory medication used for inflammatory diseases is steroids. The benefits of steroid therapies to improve symptoms and quality of life are highly supported. The use of oral steroids, however, is significantly limited by the systemic side effects. And so for this reason, topical steroids for chronic rhinosinusitis really serve as the primary first-line medications used in disease management in these patients. Nasal steroid sprays are widely prevalent as over-the-counter purchases now that patients can use. And so the image on the upper right side shows the use of a nasal steroid spray like fluticasone, mometasone, budesonide nasal sprays, which can be purchased over the counter. The use of nasal steroid irrigations or steroids delivered by an exhalation delivery system is is, in my view, the next level above the use of a nasal steroid spray. The image on the lower left side shows the use of an exhalation delivery system. This is a contraption that allows patients to exhale at the time of spraying the medication into the nose. This is a contraption that does require a prescription, and it can be prescribed to patients who have chronic rhinosinusitis with and without nasal polyps. And then with the use of nasal steroid irrigations, if I'm telling patients to perform nasal saline irrigations for routine nasal hygiene, I can also prescribe a topical steroid, which they add into the nasal saline. And then as part of their nasal hygiene process, they can also deliver the topical steroids into the nasal cavities as a way to reduce the inflammation causing chronic rhinosinusitis. There are on the lower right side of the images, we are able to see a steroid-eluting stent, which allows for the direct as well as the prolonged deposition of steroids into the sinuses through the placement of a bioresorbable stent into the nasal compartments. These stents are specifically used for patients with nasal polyps who have previously opened sinus cavities. So these are patients who have undergone prior sinus surgery. So when counseling patients about the use of steroids for the management of chronic rhinosinusitis, I really highlight the importance of topical steroids as a long-term and safe option for reducing the amount of inflammation that is contributing to their symptoms. It's important to emphasize the correct application of nasal sprays. Very commonly, patients will direct the nozzle into their nose and they point it towards their nasal septum, which can result in excessive nasal dryness as well as resultant nosebleeds. And that discourages patients from continuing to use nasal steroid sprays. So the correct application of using nasal steroid sprays is directing the nozzle into the nasal vestibule and then pointing the nozzle away from the nasal septum or towards the ears so that the sprays get delivered into the middle meatus, into the nasal cavity and not onto the nasal septum. I also emphasize to patients that there is also a graded approach to using topical steroid options, and this is based on delivery techniques. So when patients oftentimes come to see me, they've already been started on products like fluticasone, Nasonex, and budesonide nasal sprays, and that's when I'm able to counsel them about considering the use of topical steroids as administered through the exhalation delivery system or through the nasal irrigation route. So many patients do hold the common misconception that antibiotics are a panacea for all sinus diseases. Of course, this would be correct if there is an infectious etiology to sinonasal complaints, but in most cases of chronic rhinosinusitis, the underlying disease process, again, is attributed to be inflammatory and not infectious. The evidence supporting the use of IV and topical antibiotics and antifungals in chronic rhinosinusitis is thus extremely limited. It's further now, as I mentioned before, to avoid the injudicious use of antibiotics for treating patients with chronic rhinosinusitis. Of course, it's important to evaluate patients, perform nasal examinations in order to determine if there is an actual acute bacterial exacerbation to a patient with chronic rhinosinusitis, because if there is evidence of any mucopurulence within the nasal cavities, then the use of antibiotics would be warranted in these cases. Macrolides, however, are a group of antibiotics that have been shown to potentially improve patients with chronic rhinosinusitis' symptoms, not because of their antimicrobial properties, but because they also have anti-inflammatory and immunomodulatory properties. And this is an area that is being investigated within our field at this time, so that we can better understand the benefits as well as the potential harms of using macrolide antibiotics in patients with chronic rhinosinusitis. So what do I tell patients if they come to the office with chronic rhinosinusitis and also questioning about the use of antibiotics? I tell patients that, unless there's any evidence of an active infection, I don't recommend treating them with courses of antibiotics. And I make an effort to involve them in the evaluation. With nasal endoscopy, it's easy to show patients what the nasal examination demonstrates. So I'm able to demonstrate to the patients that whether or not there is any evidence of pus within the middle meatal compartments and nasal cavities to warrant the use of an antibiotic. So there are other medical options that may be recommended for chronic rhinosinusitis patients, although the data for these options are less robust and also more variable. These options include xylitol, as well as topical furosemide, both of which are suspected to help reduce mucosal edema by drawing intercellular water out of the epithelial tissue and also from nasal polyps. I don't really prescribe xylitol nasal irrigations or topical furosemide to my patients with chronic rhinosinusitis, but I just mention it because it is mentioned within the International Consensus Statement of Allergy and Rhinology. Anti-leukotrienes and aspirin desensitization are also additional medical options for patients. And this is especially pertinent to patients with aspirin-exacerbated respiratory disease, which is characterized by a triad of asthma, nasal polyps, as well as aspirin sensitivity. Aspirin desensitization, though, specifically requires aspirin-exacerbated respiratory disease patients to also undergo concurrent sinus disease. So there are a host of other medical therapeutics that are available for patients with different subtypes of different phenotypes as well as different endotypes of chronic rhinosinusitis. But it's an area. Medical therapeutics is an active area of investigation within our field. So biologics are currently indicated for severe nasal polyps that are uncontrolled by our current standards of care. There have been several biologic agents that have been improved for use for nasal polyps, including dupilumab, which was approved for use in the late 2010s, and then omalizumab in 2020, as well as mepolizumab in 2021. The use of biologics for the management of chronic rhinosinusitis with nasal polyps, it isn't indicated for chronic rhinosinusitis without nasal polyps at this time, but the use really deserves several hours of discussion, and so we won't be doing that today. But please just be aware that biologics are a new and powerful medication category that is changing the way that we're able to manage patients with the most challenging nasal polyps. Of course, there are many factors that contribute to the selection of biologic therapies for the treatment of nasal polyps. The role of endotyping has certainly been recognized to help in personalizing biologic therapies. I mentioned that endotypes, the most general way of endotyping chronic rhinosinusitis with nasal polyps involves the type 2 versus non-type 2 schematic. And so the biologics that we have available for nasal polyps today are generally type 2 biologics, which target the different molecular, the cytokines as well as the molecular cells within the type 2 inflammatory pathways. Furthermore, patients on medical comorbidities such as asthma as well as aspirin exacerbated respiratory disease also play an important role in the decision-making process of starting patients on biologics, as these patients have traditionally been more recalcitrant to routine medical therapy. Likewise, a prior surgical history also plays a role in starting a patient, determining whether a patient is a good candidate for a biologic agent. So as discussed, chronic rhinosinusitis is generally a chronic condition that can be managed medically, but patients with chronic rhinosinusitis, which is refractory to the most conservative forms of medical management, also become candidates for surgical intervention. Research has shown that as many as 14% of chronic rhinosinusitis patients undergo endoscopic sinus surgery at least once during their lifetime. And that's where we as rhinologists come in, because we can also perform sinus surgery in these patients after we've worked them up, and then also managed them initially with medical therapy. Endoscopic sinus surgery has demonstrated its merits as a treatment option through well-established research, high-level research studies showing both subjective as well as objective improvements in outcome measurements, including patient-reported symptoms as well as quality of life. The introduction of new instrumentation and advancements of surgical techniques have allowed for the continued growth of endoscopic sinus surgery as a treatment option for chronic sinusitis. Today, over 250,000 cases of endoscopic sinus surgery are performed annually in the United States and constitutes about 43% of nasal surgeries performed per year. Now, what are the key objectives for performing sinus surgery? I oftentimes will tell my patients that sinus surgery offers both diagnostic and therapeutic benefits so that we can simultaneously better understand the nature of the disease endotype and also provide some form of therapy. The goals of surgery are to improve subjective sinonasal symptoms and to remove relevant foci of disease, such as polyps, accumulations of mucus, and sometimes fungal and purulent debris. Other goals are for post-operative maintenance of chronic sinusitis as a long-term disease, such as to restore the disturbed ventilation and drainage pathway of the paranasal sinuses, and most importantly, really to enhance the post-operative use of topical medications following surgery. So with surgery, I tell patients that surgery isn't a cure for chronic rhinosinusitis. It is a medical condition that needs to be managed with medications following surgery, and part of the reasons to one of the reasons to consider surgery would be to widen the access points into the sinuses so that topical therapies can better reach the sinuses following surgery. So I recognize that surgery is best learned visually. So here's a video demonstrating performance of maxillary antrostomy. The patient's CT scan was on the previous slide, which showed complete opacification of the maxillary sinus. So here you can see that in surgery, I'm able to palpate the tissues, try to drain the infection that is evident in the maxillary sinus. I'm also able to remove tissue so that we can widen the drainage pathways to the sinuses. So after the surgery, what was initially a big blob of tissue, edematous tissue within the nasal cavity, has now been removed so that we can look directly into the maxillary sinus on the right side, into the ethmoid sinuses straight ahead. And we're able to evacuate the long-term infection that was causing the opacification on the CAT scan in this patient. So despite the importance of surgery in the treatment of chronic rhinosinusitis, as I've mentioned, medications remain at the forefront of therapy. With all of these recommended treatment strategies for chronic rhinosinusitis, it is important that the medications be both efficacious and safe, and more importantly, that the patients are also willing to use these medications, because patient compliance is critical for the success of chronic rhinosinusitis treatment. For this reason, it is critical that we recognize that there are many considerations that influence whether patients will be compliant with or wish to pursue a specific therapy. The efficacy, safety, and tolerability of the medication certainly are factors that will encourage patients to continue using the medications like nasal saline sprays, irrigations, and topical topical steroid therapies. Patients, may not, in my practice, may not be willing to perform nasal saline irrigations because they say that the performance of nasal saline irrigations causes a lot of discomforts. In those cases, then I have to go back to recommending the use of nasal steroid sprays to this patient, or even consider using something like an exhalation delivery system for patients who are not able to tolerate nasal irrigations. And of course, availability as well as cost of medications will also determine whether patients can be started on specific medications. So expert statements regarding treatment algorithm to manage chronic rhinosinusitis have previously been published by multidisciplinary leaders in the field. In this specific publication from 2021, both Dr. Han and I, Dr. Han is a rhinologist here at EVMS, we were able to formulate a stepwise treatment algorithm based on the evidence as well as the different authors' clinical experiences. The actual publication has a very comprehensive graphic that shows the different stepwise approach that is reasonable for starting at the least invasive ways of treating patients with chronic rhinosinusitis to the most invasive, but the schematic is pretty detailed. And so for this for this reason, I created a, in my mind, to simplify this algorithm, I created a ladder of therapies that can be utilized that can to reach the ultimate goal of symptom relief for patients. We basically start at the lowest rung, which includes nasal saline irrigations, as well as topical steroid sprays, and then we can gradually move up to the higher rungs if needed. Individual steps are not absolute. And may be skipped or interchanged if needed. And I found this approach has been very helpful to help patient understand the diverse options of therapies we have available for managing their disease at this time. So this brings to the conclusion of my presentation. I hope I've provided a comprehensive highlight of chronic rhinosinusitis as a chronic inflammatory condition that may affect many of our patients. Although there are many disease phenotypes and endotypes, the goal for us as providers is to find treatment strategies to help reduce the patient's disease-specific symptoms and improve their quality of life. This treatment can be offered with medical therapeutics, which I have highlighted, although surgery can also be offered to those who fail initial medical therapy. Given the large number of options that we have in pursuing treatment, however, patients are increasingly becoming more involved with choosing what best suits them. So I will open this up for questions. I want to thank everybody for taking the time to listen to me talk. I apologize for my voice. Yeah, just because of my illness. So thank you everybody for listening.
Thank you, Dr. Lam. That was a wonderful presentation. With this, the house is open for questions. Dr. Weaver.
So, Dr. Lam, this is Christian with the infectious disease group here. I have a couple of patients that I follow that are mostly seen by you as well too. But sort of like where in this care cascade would you recommend us getting ENT involved in a lot of these cases? Because, we see patients that we can put on topical corticosteroids and other things like that and not have to refer them out to ENT. Sort of where do you foresee getting involved in a lot of these patients?
Right. So I think, for us, I think it's very helpful if the patient has really tried using intranasal steroid sprays as well as nasal saline irrigations before they come in to see us. That gives us more because if patients can achieve the symptom relief that they're looking for with steroid sprays as well as irrigations, then they don't really need to spend the extra time to come and see a specialist. It's a whole nother trip for them, to another set of doctors and healthcare providers to see. So if they can be managed with their nasal symptoms, with the use of steroid sprays and nasal irrigations, then that should be fine. But if they still complain about symptoms following a trial with steroid sprays, then it would be helpful for them to come and see us. We can perform a nasal endoscopy to ensure that it's nothing more worrisome than a chronic inflammatory condition.
Dr. Tahan?
Hey, Sami Tahan from General Telemedicine. Can you comment, and I may have missed it, what is a adequate trial of intranasal steroids and nasal saline irrigation duration-wise?
Right. So there isn't a standard duration of therapy for this medical trial. Generally, we will say about 4 to 6 weeks. So it is important for patients to be using steroid sprays consistently every day for about 4 weeks to see if we are able to achieve the relief that they're looking for.
Great. We do have one question from Dr. Graf on Zoom. How often does deviated septum or other anatomical variants of sinuses contribute to chronic rhinosinusitis? And does this change algorithm favoring surgical intervention?
So yes, so chronic rhinosinusitis, there's an inherent inflammatory cause to the disease, but there's also a mechanical obstruction as well that can result in the propagation of disease. So a deviated septum can result in narrowing of the nasal passageway. It can result in blockage of the osteomeatal complex, which is the drainage pathways leading from the sinuses out into the nasal passageways. So yes, so a deviated septum can compound a patient's nasal obstruction. It can also propagate the chronic rhinosinusitis. For patients with a deviated septum, we always want to start with a medical trial as well, before we consider surgery. But if we do talk about surgery for patients with chronic rhinosinusitis, we can definitely fix a deviated septum simultaneously.
Thank you. With this, we'll wrap up the grand rounds for today. Thank you, Dr. Lam, for your time. It was a pleasure to have you.